Okay.
All right. Well, good morning, good afternoon, and good evening to everyone around the world. Thank you so very much for joining us for our very first University of Pennsylvania case competition worldwide edition. We are representing the emergency department here at the University of Pennsylvania in Philadelphia in the United States. And we're doing this in collaboration with the Center for Global Health at the University of Pennsylvania as well, too. So welcome all. It is a pleasure to have you all here. We are honored to have a good group of abstracts to present today. And it's my honor to help host this. My name is Dr. Megan Robarczyk. I am an associate professor of emergency medicine here at the University of Pennsylvania. I'm here with several of my colleagues from our Department of Emergency Medicine, as well as the Center for Global Health, to host this competition today, to provide the judging, and to overall have a wonderful environment to learn from each other here. So thank you again so much for joining. I want to move on to next our keynote speaker. Our keynote speaker today is Dr. Ghazanfar Salim. He is from the Indus Hospital and Health Network in Karachi, Pakistan. He completed his fellowship in internal medicine actually in 2014 from the College of Physicians and Surgeons in Pakistan. And he joined the Indus Hospital and Health Network, or IHHN, as a consultant in the emergency department shortly after that. He is now currently the chair of the entire emergency medicine service line for that entire health network all across the country. And he's head of department for the data science and analytics department at IHHN. His areas of interest include the development of emergency care through leveraging clinical data and education. He has been a colleague of mine since 2017 when we co-founded the Certification Program in Emergency Medicine, or the CPEM program in Pakistan. That program is now in its 5th cohort. I believe they train more than 150 physicians from all across the world, not just Pakistan, but all across the world. And it's been an amazing program that has since then spun off pediatric programs, leadership training programs, research, all kinds of things. So Dr. Ghazanfar is an exceptional clinician in emergency medicine, a researcher, a speaker, a colleague, a mentor, and a friend. And I'm very honored that he is joining us today as our keynote speaker with his talk entitled From Silos to Synergy, Equitable Partnerships in Emergency Medicine Across Borders. So Dr. Ghazanfar, over to you.
Thank you, Dr. Megan, for such a nice introduction. And thank you for Center of Global Health for having me in this session. Can I share my presentation?
Yes, you should be able to do so.
Okay. Introduction has already been done by Dr. Megan, and the topic is From Silos to Synergy. This is basically a lower foot entrance that I put in from my starting slide of the presentation, and it shows narrow path. And once you go through that unwinding narrow path, you will ascend to a platform where you see a lot of good things. The whole fort is visible from upside. So this is basically prelim to this thing that this equitable partnerships are the narrow path, but once it is done, it improves things around. So what I'll be discussing in this presentation is basically understand the changing landscape of the global emergency medicine. I will be discussing about the principles of what are the equitable partnerships between high income and the low income countries, how partnerships impact clinical service delivery, education, research, quality improvement. Also, the importance of embedding diversity, equity, and inclusion in partnerships, and explore how medical ethics and cultural sensitivity shape successful collaborations. According to the Paul Farmer, a renowned physician and global health expert, partnership is not a strategy, it is a stance. Why do we need collaborations? So, why do we need collaborations? Because LMIC bear a disproportionate share of global emergency care burden. There's like a patient's disease burden in LMIC is a lot as compared to the HIC, and we see a lot of complications of those diseases as well. Isolated effort leads to the duplication and unsustainable interventions. Also, joint learning improve the knowledge and improve systems on both sides. And in strengthening emergency care aligned with the WHO's universal healthcare coverage goal. This was basically published in Emergency Medical Care in Developing Countries. Is it worthwhile? At the bulletin of WHO by Razak et al. It's not moving. Are you guys able to hear me?
We are able to hear you.
Okay.
Mhm.
So current inequality. What are the current inequalities in HIC or LMIC emergency medicine collaboration? So definitely HIC institutes, they are the funders. So they set up the agenda, they set up the authorship criteria, they set up the decision-making things. LMIC authors are usually underrepresented in the global publication. It was basically a systematic review was done for authorship and collaborative health research in Africa 2014, from 2014 till 2016, and published in BMJ Global Health that this is what it is talking about. So LMIC partners lack equivalent access to infrastructure training. Definitely. And then there is a problem is the travel costs, visas, and the institutional supports. Institutes in LMIC, they don't support people. They usually don't support people in traveling to the high income countries so that they can be trained better. So often there are interventions that are overlooked because the cultural differences, the community needs, that leads to the ethically inappropriate or unsustainable programs that basically fall once the project is completed, the programs are gone. These short-term projects, they neglect sustainable capacity building. They are dependent, they are fragmented. So what is the equitable partnership? According to the global health partnerships, it should emphasize, it should be symbiotic, like mutual benefit. It should not be donor-recipient relationships. Share, there should be shared goals and responsibilities across all the project stages, and ensure that the local leadership is developed through those. And there's contextual relevance as well. That includes financial transparency and the fair distribution of the resources that are available during those partnerships. Rooted in the principles of partnership that respects learning, and then there is basically sustainability in those partnerships as well. The global health paradigm has changed a lot. And since COVID, everybody has witnessed because of the distances have shrinked, and we, as I am sitting in Karachi and delivering a talk in USA, and this is basically happening around. And you see, they are like LMICs are doing a lot of stuff, a lot of things that should be shared with the HIC so that both can learn together. It should not be, it should be directional, not it should not be unidirectional. It should be bi-directional. It should be co-developed. The LMICs have expertise in managing the health challenges. It should not be like extractive models like parachute or research. And advocacy for the global reciprocity and the long-term relationship should be there. How do we improve it? Service provision and the shared solutions. LMICs offer real world innovations because in LMICs, there is a term that we use in our language. It is called jugaad. In social media, you can say that it is technologia. HICs contribute to the standardized tools, protocols, and technology. They co-design them. This can co-design emergency care models that can yield higher local adoptions. And the joint protocols then improve outcomes, not only in LICs, but it improves the outcomes in the LMICs and the HICs as well because of the cost effectiveness. Just like this WHO trauma checklist that was developed by physicians working all across the globe, and they came up with this trauma checklist that is available on the WHO website. Further, we can improve education and training through joint effort. Joint curricula should be developed between HICs and LMICs learners. LMIC basically offers the broad pathology, and this context-specific learning improves both sides. And HIC can contribute through simulation, through focus, and faculty development tools as well. Co-teaching models foster mutual professional development. Good example is, as already told by Dr. Megan during her intro, that CPAM. We started this program in 2018, and we have trained a lot of physicians, not only from Pakistan, Karachi, Pakistan, but a lot from outside Pakistan as well. So we offer contextual and the global learning. It is a good example for that. You should realize that when you are, whichever country you are working, what are the cultural context of this country and what are the neighbors during those things as well. So in this hospital and health network, what we are doing, we are 12 there are 12 multidisciplinary hospitals with 3 physical rehabilitation centers, 4 regional blood centers, 100 plus primary care sites, and multiple public health initiatives. This is the whole Indus Health Network. And this is an expanding network that is continuously expanding. We are present all over Pakistan. There are 12, those 12 hospitals have 12 emergency departments. And how do we improve those emergency department situation? Through different training programs that we have adopted, like the certification program for adult emergency medicine, pediatric emergency medicine certification program. Then we developed a collaborative advanced trauma care course with the help of Emory University. Uh, and then there is WHO ICRC BEC course, and with the help of Penn University, Dr. Megan, there we developed ED leadership course that we have already taught in Karachi 2 times. How do we research mutual benefit? This is basically a Canadian Coalition for Global Health Research points that research should be inclusive with shared benefits, commitment to the future, and responsiveness to cause inequalities, and humility and authentic partner. Basically, LMICs have untapped clinical and epidemiological data. HICs offer methodological expertise and publishing support. Joint priority setting ensures relevance and ownership, and equity in grant writing and budget control is very essential. This improves the condition of LMICs, and not only the LMIC patient outcomes, but also develop the faculty to do their own researches as well. Once you start doing the researches, you can identify the burden of the disease that is present with you. This basically is Trust, a global alliance for the global conduct of ethical research in resource poor setting, that was basically founded in 2018. And it shows that it should be inclusive. The research should be inclusive. So they have developed certain ethics of the research as well. Joint research, what are the joint research ethics? It should be adherence to the local IRB and the international ethical standards. We should avoid data extraction without benefit to the local system. It should not be like that data is extracted just for the sake of research, and there is no benefit to the local system from where the data was extracted. And it should build the LMIC, because in LMIC's research infrastructure is not good. So it should be like that. It should build up the research infrastructure of LMIC and the authorship capacity. It should ensure community engagement and informed consent adopted to the context. And it should be guided by the best practices and research framework. It should be community engaged. So cross-pollinating quality, what can we learn from each other? What LMICs learn from HICs? In HICs, you will have standardized quality information frameworks and patient safety protocols, use of health information systems, and the data analytics, simulation-based education, and the protocol-driven care. That is usually LMICs lack those things. But what HICs can learn from LMIC? We offer low-cost, context-adapted triage and the flow solutions, and we can embed quality information and to the frontline survival strategies. then the road is much more clean, as you can see in the picture. How we can improve the cultural sensitivity and the medical ethics. Ethical frameworks must account for the local norms and belief systems. It should engage the local cultural and community leaders. Should not be like one size fits all ethical assumption. Cultural humility, like lifelong self-reflection and the power awareness, should be there. We should ensure that gender, ethnic, and the geographic diversity in leadership is there. We should avoid token inclusion in the global research and authorship. We should address structural barriers like visas, funding, and the language biases that is usually there. And we should stay clear from the publication discrimination. Like if somebody is not publication, there is no publication, then they are discriminated. It should be avoided. We should avoid top-down design and hidden agendas when we are doing collaboration with LMICs. Respect the LMIC partner bandwidth, avoid parallel projects. We should avoid helicopter mentoring. It should not be there. Don't overclaim outcomes that LMIC teams cannot sustain. The agenda should not be like high-end things that are not present in the LMIC and people start doing those things in the LMIC, and once they go out, they take their things out with them as well. Use MOUs with clear governance. This will help in improving the collaborative partnerships. We should be co-creation. There should be a clarity in roles and responsibilities. Co-leadership should be there, like equal roles in the leadership in decision making. Capacity exchanges should be there, like skill transfers from both directions. And then should be long-term planning beyond the project cycles. Like once the project is down, how we can see that the project is sustainable or not. Policy and advocacy partners can, because with LMICs, there can be a good advocacy by the HIC partners to lobby the ministries and then donors for the emergency care funding. There should be a shared policy brief from HIC to LMIC academia teams that should carry weight as well. We should collaborate together to establish EM as a specialty in LMIC. Should use the World Health Assembly Resolution 72.16 as advocacy tool for national EM policy. And joint disaster preparedness guideline should save life during the pandemics like that happened during the COVID time, when we collaborated with a lot of institutes from USA, and that helped us in improving our patient outcome as well. What should be the way forward? Equity in metrics, it should not be just outputs. Investment in regional collaboration facilitated by the HIC. Creation of inclusive authorships and conference participation. Focus on systems strengthening, not individual heroics. Agendas should be co-created, led by the LMIC priorities and informed by the HIC support, ensuring shared governance and mutual accountability. Culture makes people understand each other better, and if they understand each other better in their soul, it is easier to overcome the economic and political barriers. But first, they have to understand that their neighbor is in the end just like them, with the same problems, the same questions. This quote was either by Paul Chaulo or Ernest Hemingway. Thank you. Any questions? Any questions?
I'm monitoring the chat and the Q&A for you, Dr. Ghazanfar. I don't see any in the chat and none currently in the Q&A. Getting several reactions of applause though. Yes, that was such a wonderful talk. Thank you so much for sharing. Such an interesting, comprehensive overview of looking at partnerships between areas of the world with varying resources, and particularly areas of the world that are resource denied. And so that partnerships are definitely the way to expand emergency care delivery worldwide. So thank you for outlining those best practices. As we're wrapping this up, any questions for Dr. Ghazanfar Salim? All right, if no other questions, again, thank you so very much, Dr. Ghazanfar. We will now move into the next part of the case competition, the abstracts. So what we're going to be doing next is the first 10 abstracts in no particular order. Then we will have a brief intermission for about 10 minutes, just to give everyone a little bit of a break. And then we will come back and do the last 10 abstracts again in no particular order. I'm very excited to say that we had over 70 submissions for this case competition from all over the world. And the top 20 abstracts that you're going to hear now are from 9 different countries across 4 different continents. So truly a representation from across the world. And to Dr. Ghazanfar's point of thinking about education and training and partnerships, the purpose of this today is really to all learn from each other, to share information about interesting cases, and help us to overall improve emergency care worldwide by sharing this educational session with you all. So without further ado, I'm going to turn it over to my colleague, Dr. Joseph Ciano, who is here in Philadelphia, and we will start with the first abstract for the day.
Am I audible? Okay, so I will be introducing briefly each of the speakers, and then we will be playing their presentations in order. So first we'll be starting with Dr. Odumako from Ghana.
Hi, my name is Dr. Eugene Kojo Adomako, and today my case I'm going to present is titled Spontaneous Hemoperitoneum from a Ruptured Vessel Overlying the Subserosal Myoma, Life-Threatening Emergency in Women. Now, I have no financial conflict of interest. I have no affiliations that influence clinical decision making in this case, and patient information have been de-identified for privacy. This was a 41-year-old multi-parous woman. At the time of presentation was part 3, with her last delivery 2 years ago via cesarean section. This was followed immediately with a bilateral tubal ligation during that delivery, and then she had also had no remote or acute trauma, and she had no current pregnancy via any other means, and also had no vaginal bleed. She presented mainly with syncope and sudden onset severe abdominal pain, which started the same day. She had multiple bouts of syncope. Typically, each episode lasted about a minute. There was no abdominal jerky movement noted, and there was no loss of bowel or bladder continence. Now, abdominal pain following the sudden nature was non-migratory or non-radiating. It was exacerbated by light, small movement and mildly relieved by flexing the knees. She had taken some pain medication, but it was not resolving. Also reported to a near facility where pain medication was given, but availed not much. And so patient was referred on account of the refractive nature of the pain. Now, on arrival to the emergency, the patient appeared lethargic and acutely ill. Her initial assessment showed patent airway. Oxygen saturation was 98% on ambient room air, and she had normal respiratory rate in the clear lung fields bilaterally. She presented with hypotension as noted over here. Her blood pressure was 86/59, and the pulse rate of 121 beats per minute. Although she was pale and lethargic, she maintained full consciousness. There was no history of trauma or falls, and abdominal distension, jaundice, or fever was also not noted. The exam reviewed. Abdominal exam also reviewed papillary tenderness with no GAD, and no pulsate abdominal mass was noted. And she appeared pale, lethargic as already noted, but maintained full consciousness and was not confused. Now, few differential diagnoses were entertained was a ruptured ectopic pregnancy, ruptured hepatoma, visceral artery aneurysm, and a splenic fracture since within the malaria endemic region, and that even though rare could also occur, and ruptured abdominal aortic aneurysm. Some lab investigations were obtained included the glucose levels because the initial assessment proved to be elevated, and this was followed up subsequently. Serum ketones that followed it because of concerns of diabetic acidosis was however within normal range. Complete blood count reviewed an HB of 6.4 grams per deciliter. Platelets and white cell counts were in normal range, and a urine pregnancy test that was sent earlier came back as negative. So point of care ultrasound was used in a RASH protocol, which rapid ultrasound from hypertension was invoked. And by so doing, we found a large volume of intraperitoneal fluid with low level echoes, which was signs of hemoperitoneum. The collection was of varying echogenicity in also the subhepatic recess and likely to be clot or hematoma. Now, this is the ultrasound that shows the collection in the suprahepatic recess. And the right, you can see right the liver over here, and the diaphragm showing over here too. Also, what we identify as a clot is what is labeled over here as H, the liver here, and then the right kidney here. All the other things that are part of the RASH protocol were done and was not normally found. This was a clinical cause. An urgent surgical consult was obtained because of the likelihood of hemoperitoneum. So a patient was given 1 liter of IV fluids. In total, patient received 7 units of blood and 5 units of fresh fusion plasma. And then this was in total, some at the emergency, some during surgery, when patient's surgery was after the surgery was done. Now, an exploratory laparotomy was done by both the surgical and gynecology team. And what was noted was an active bleeding from a dilated superficial vein over a large subserosal fibroid. 5 liters of hemoperitoneum was evacuated. The procedure performed subtotal hysterectomy and a bilateral appendectomy. The outcome of the surgery was mainly normal or fine. Patient was stabilized postoperatively and she was discharged postoperative day 8 with full recovery. Now, this goes to talk more about the point of care ultrasound and how it's critical in the rapid evaluation of hypertensive patients, especially when advanced imaging is delayed or unavailable. Also, it helps in the immediate diagnosis of it's an essential for life-saving intervention. In this case, the use of the RASH protocol enabled early detection of life-threatening hyperperitoneum, exclusion of other shock causes, and rapid surgical triaging was also done, and it aided in interdisciplinary coordination. So the teaching point noted here is that in a reproductive age, or in a reproductive age woman presented with shock and acute abdomen, we should consider spontaneous hyperperitoneum from a ruptured vessel, and which is a rare life-threatening emergency. Also, the point of care ultrasound study RASH protocol is an essential bedside tool for timely diagnosis and distribution. These are my references. Thank you very much. Hi, my name is Dr. Eugene Kojo Adumakun.
Okay, for our second presentation, I will be introducing Dr. Fetcher from South Africa.
Hi everyone, I'm Ludwig Gechter, and today I will be presenting our case of an abdominal mass and heart failure. This happened at Helen Joseph Hospital Emergency Department in South Africa, and my mentor is Dr. Duplessis. We have no financial disclosures and the appropriate consent was obtained. To sketch a little bit of background, we work in an urban tertiary hospital emergency department where the services of obstetrics, gynecology and pediatrics are not offered on site. These services are offered at our sister hospital, Rima Musa Mother and Child Hospital, from where this patient was referred, as we have internal medicine. So jumping in, it's a 35-year-old female. She's gravida 3 para 3. She was referred from Rima Musa Mother and Child Hospital Emergency Department with a concern for new onset heart failure. The patient was reviewed by gynae, noted that she had a uterine mass, but that she was known with a multifibroid uterus. The patient was transferred to Helen Joseph Hospital Emergency Department for further management of her heart failure. The patient had a month history of PV bleeding, requiring 1 to 2 pads per day, and now complained of progressive dyspnea, orthopnea, bilateral lower limb swelling, and lower abdominal pain. A urine pregnancy test done at the referring facility was negative. On physical examination, she was tachycardic, tachypneic, had high blood pressure, saturating well on nasal cannulae, and was afebrile. On presentation to us, the patient was in severe respiratory distress and taken to resuscitation bay to initiate non-invasive ventilation. Point of care ultrasound revealed a mild moderately reduced ejection fraction, normal ventricular ratios with a negative McConnell sign and a negative D sign, a plethoric inferior vena cava, bilateral pleural effusions, diffuse B-lines, and an abdominal mass. ECG showed right axis deviation, and voltage criteria were met for left ventricular hypertrophy. There was also some inferior T-wave inversion. A urine pregnancy test was negative. This was the ECG, which internal medicine thought suggested a pulmonary embolism. We had a good conversation about our point-of-care ultrasound findings, and it was decided that if the patient was stabilized, she could later go for a CT pulmonary angiogram. This was the suprapubic transverse view on point-of-care ultrasound, and if you were thinking about a bunch of grapes or a snowstorm appearance, you're absolutely right. The diagnosis was gestational trophoblastic-induced thyrotoxicosis with a high likelihood of thyroid storm. So in terms of laboratory findings, the patient had a significantly raised beta ECG. Also of interest, when internal medicine later did a urine pregnancy test, it was faintly positive. The TSH was significantly low, T4 significantly raised. The full blood count wasn't significantly abnormal, and the patient had an acute kidney injury. In terms of treatment, the patient was placed on non-invasive ventilation. As mentioned, we started the patient on diuresis. Internal medicine decided to initiate the patient on a low dose of propranolol. We initiated the patient on hydrocortisone, and then internal medicine, in consultation with endocrinology, advised not to administer carbimazole and Lugol's iodine, as they believed the patient was unlikely to be in a true thyroid storm. The patient, however, significantly improved on the above treatment and was transferred to Hima Musa Mother and Child Hospital Obstetrics and Gynecology for a dilatation and curettage under ultrasound guidance. Important teaching points. So take the hocus out of pocus. If you needed another excuse to do point-of-care ultrasound on almost every patient, this might be it. Another important thing, gestational trophoblastic disease has an outstanding cure rate, and therefore we as emergency practitioners have to be aware of it. Another thing is the hook effect. That's when an excess beta ICG antigens are present in the urine, and it may overwhelm the finite amount of antibodies present in the point-of-care urine pregnancy test. This creates a false negative, known as the hook effect, which likely explains the initial negative urine pregnancy test and why it was positive after diuresis. Lastly, emergency medicine is a team sport, and if we work together, we can truly impact patients' lives. These are my references, and thank you very much.
Our next presentation will be from Dr. Ibrahim from Nigeria.
Okay. Hi, everyone. My name is Amina. I'm an emergency medicine resident from Nigeria. And thank you for the opportunity to be here today presenting at the 2025 Penn Global Emergency Medicine Clinical Case Competition. So I will be presenting a case titled Beyond the Obvious. And this is a case of cerebral malaria masquerading as substance-induced seizures in an emergency setting. I'll be presenting on behalf of my mentor, Dr. Tunde Shaolu, and the rest of my team members. So I have no financial or non-financial relationships or conflicts of interest to disclose. So let's get into the case. So this is a case of a 41-year-old man who presented to the emergency department, and he came in with a history of 3 days of headaches as well as generalized weakness. So symptoms had been getting worse over the last 3 days, and then he had self-medicated by taking a traditional herbal medication, as well as started on some anti-malaria tablets. However, his symptoms continued to worsen, and in the 24 hours leading up to presentation, he had become extremely restless. He was noted to be very agitated by family members and was sweating a lot. So he started experiencing seizures. They were described as generalized tonic-clonic, and he had had 2 seizures at home before presenting to a district hospital, where another seizure was aborted with IV diazepam, and then he was subsequently referred to our hospital. While in our emergency department, he went on to have another seizure. So before now, he had no previous history of seizures. However, he did have a background history of substance use. So he had been struggling with the use of cocaine as well as alcohol. He had been clean in the year for about a year leading up to this. However, his wife noted that he had relapsed and had started drinking excessively in about 3 days before the onset of the illness. He had no other comorbid illnesses. Okay. So on examination, when he came in, his vital signs, he was tachycardic with a pulse rate of about 147. Blood pressure was fine, though he was tachypnic. Oxygen saturation was about 94% on room air, so he was started on oxygen. Initial temperature was fine. However, about 30 minutes later, it was rechecked and he had a fever of about 39.2 degrees. His pupils were dilated as well as sluggish, and other aspects of the cardiovascular and respiratory system examination were essentially normal. Central nervous system examination, he had no focal neurological deficits. GCS at presentation was about 10/15. However, following another seizure, GCS dropped to by 6/15. We also passed in a catheter to measure his urine output, and he had red-colored urine. And at this point, we started thinking, does he have rhabdo or another cause of hemoglobinuria? So our differential diagnosis at this point was substance-induced seizures, given the fact that he had started drinking alcohol again, as well as his past history of cocaine use. We also did think about central nervous system infection, so we were thinking, could he have meningitis, encephalitis, or even cerebral malaria, as malaria is endemic to Nigeria. We also did think it was important to rule out a stroke, and so he had a CT done to do this. So investigations were done, and his investigations pointed towards a diagnosis of cerebral malaria. So he had a malaria test that was positive, and he had a smear done, and it had 3+ of Plasmodium falciparum, which means that he had more than 10,000 per high power field. He had thrombocytopenia, a hyponatremia, his liver enzymes were elevated, CT scan was normal, and toxicology was negative. So this basically helped to rule out the other differentials, and we had a diagnosis of severe malaria or cerebral malaria. Okay, so management, so he was admitted into ICU, intubated, and started on mechanical ventilation. Seizures were controlled with seizure medications. He was started on fluids and other supportive care, as well as IV artesunates after the treatment, after the confirmation of the malaria parasite, as per WHO guidelines. However, despite these interventions, he did pass on within 24 hours. So what this case really taught us was that how important it is to basically not to anchor on an obvious diagnosis and cast an open net, because people who come in with altered mental status could have a wide variety of diagnoses. At the same time, it's also important to consider diseases that are endemic. So despite the fact that he didn't fit within the normal demographic for cerebral malaria, this was the diagnosis in this care. It also did draw attention to the fact that delayed diagnosis can have devastating outcomes, as was the case here. So it is important that we're able to access diagnosis quickly and be ready and prepared for things like this when they happen. Thank you. These are my references. Okay. Hi, everyone. My name is Amina.
I got you.
Our next presentation is from Dr. Fatima from India.
Good morning, everyone. I'm Dr. Ria Fatima. I'm a second-year radiology resident from Kerala, India. This is my case presentation titled, Silent Spill, Sudden Spill, the Explosive Onset of Choriocarcinoma Syndrome. Presenting complaints. A 22-year-old male presented to the emergency room in the middle of the night with complaints of right upper quadrant abdominal pain of 1-day duration, now associated with breathlessness and dizziness. History of present illness. The right upper quadrant pain was acute in onset, dull aching type of pain radiating to the epigastrium for 1-day duration associated with nausea, no history of fever, vomiting, or jaundice. Breathlessness was acute in onset, non-positional, no chest pain or wheezing, and no prior history of cardiac or lung disease. There was generalized fatigue and lightheadedness associated with profuse sweating. Past history. There is no non-comorbidities, not on any medication, no history of substance abuse, and no relevant family, social, or personal history. Coming to the primary assessment. The patient was drowsy and pale at the time of examination with a patent airway, and the saturation was 92% on non-breathing mask. There was tachypnea with a respiratory rate of 24 per minute with increased worker breathing. There was decreased air entry, bilateral lung raise with dullness on percussion, and crepitation present. Hence, high flow oxygen with salvageable nebulization was given. Evaluation of circulation, there was tachycardia with a heart rate of 110 per minute and hypotension with a BP of 90/70 millimeters of mercury. There is increased capillary refill time and cool extremities. Hence, an IV access and the blood gases were drawn and fluid and inotropes were commenced. The ECG was normal. Disability, the GCS and RBS were normal. Exposure, the patient was fully exposed for examination and abdomen was distended and tender, and there was lumpiness in right testis. Coming to the investigations, arterial blood gas analysis, the pH was 6.8, a PCO2 of 94 mmHg, a PO2 of 55 millimeters of mercury, a base excess of 14.6, and a hemoglobin of 7.6 gram per deciliter, giving an impression of respiratory acidosis, and a low HP with the cool extremities suggesting hypovolemic shock, probably due to occult internal bleeding. Patient was initiated on BiPAP due to the worsening respiratory distress. A point of care ultrasound was done, which showed moderate sized liver masses and free fluid in the Morison's pouch and pelvis suggestive of hemoperitoneum. The source of bleeding was not visualized. The patient was started on PRBC transfusion with O positive blood. On summarizing, so this is a case of a 22-year-old male presented with acute abdominal pain and breathlessness. On examination, he was in high hemodynamic shock with respiratory acidosis. The etiological clues, right testicular mass with multiple evolutions suggestive of primary testicular malignancy with possibly ruptured hemorrhagic metastasis causing hemoperitoneum. The treatments given so far, the patient was escalated from NRBM to BiPAP due to worsening respiratory distress. Fluids and inotropic supports with blood transfusion were going. Ongoing bleeding was suspected in view of the worsening vitals. Hence, a CT angiography was done. This is a CT angiography of the abdomen, which is revealing multiple enhancing lesions in both lobes of the liver, and there was active extravasation of the contrast from the hepatic metastasis. This is a plain CT of the pelvis, which is showing hyperdense fluid, which is suggestive of hemoperitoneum, and this is a lung window, which is showing multiple cannonball-like metastasis in both lungs with diffuse ground glassing, which is suggestive of pulmonary hemorrhage. This is ultrasound of the scrotum, which is showing a well-defined heterocoic mass in right testis with vascularity on color Doppler. Meanwhile, the lab values have arrived, and it showed a hemoglobin of 7.9. The serum creatinine was normal, luckily. The LDH was elevated and AFP was also elevated, and the beta HCG was more than 2.5 lakh, which is markedly elevated with a normal LFT. So, the provisional diagnosis of choriocarcinoma syndrome with hemorrhagic metastatic deposits in the liver and lung complicated by hemoperitoneum and pulmonary hemorrhage, probably primary from the right testis. Ongoing bleeding from hepatic deposits were causing the worsening of vitals. Hence, an emergency right hepatic artery embolization was done. This is the right hepatic artery. This is the angiogram demonstrating the active tumor bleed. Later on, the patient improved symptomatically and hemoglobin values increased from 7.9 to 8.8. Presumed choriocarcinoma syndrome, patient was initiated on chemotherapy with low dose of etoposide and cisplatin to prevent tumor lysis syndrome, and is doing well and is currently on follow-up. The choriocarcinoma syndrome, which is rare but life-threatening clinical complication, which is associated with metastatic germ cell tumors, especially non-seminomatous GCT that contains choriocarcinoma elements. It is characterized by massive hemorrhage from hemorrhagic metastasis. The typical patient profile is that of a young male with metastatic GCT and a very high beta HCG, typically more than 50,000, presenting with massive hemoptysis, hypotension, or renal failure due to bleeding. Biopsy is not usually required. In fact, this is one of the malignancies where imaging findings and beta HCG is sufficient to start the treatment. Uncontrolled bleeding might require radiological interventions like hepatic artery embolization. And to the best of our knowledge, only 4 cases of choriocarcinoma syndrome managed with emergency hepatic artery embolization have been reported in literature. Here are the learning points. Examination of scrotum should not be missed out in a male patient, especially young males presenting with acute abdomen. Choriocarcinoma should be high on the differential in young males with multiple hemorrhagic metastasis and high beta HCG. A silent swelling, a sudden spillage, but with systematic approach and prompt interventions, the explosion can be diffused. Once again, thank you so much.
Next will be Dr. Bai Pakani from Botswana.
Good day, everyone. Thank you for the opportunity to speak. My name is Hofatsobe Pakani. I am an emergency medicine resident from the University of Botswana in the country Botswana. Dr. Hiwat is both my lecturer and my mentor. The title of this presentation is Managing a Critically Ill Patient in a Critically Resource-Limited Emergency Center and Community. The following are my disclosures. All images and information in the slides have been used with consent from the patient and hospitals. Any patient identifiers are cut out to protect patient identity and confidentiality. Some of the information regarding the patient was obtained retrospectively after the complete treatment course, and there are no noted conflicts of interest at this time. The history is of a 25-year-old female who presented with a 2-week history of progressively worsening lower abdominal pain and abnormal vaginal discharge associated with subjective fever, chills, malaise, and intermittent vomiting. Her socioeconomic history is that she reports previous multiple concurrent partners with inconsistent barrier contraception use. She is unemployed and an occasional methamphetamine user who is reliant on sexual partners and backyard tenders as her usual source of money. She lives alone in a shack from the community shown on the picture on the right, who left her family behind in a country to come seek better income, so she has poor social support. Her physical exam showed an ill-looking patient in pain discomfort who ambulated with a guarded abdomen. She had moderate dehydration. She looked like a toxic patient with vitals showing hypotension, tachycardia, tachypnea, and pyrexia. Her abdomen showed a lean patient with a visible mass at the right lower quadrant at about 12 centimeters with gross tenderness to abdomen palpation. She had normal external genitalia, however had a purulent, foul-smelling discharge from the vaginal vault. She had marked cervical motion tenderness. Other systems examined well, however. Her bedside tests showed a urine pregnancy test were negative with positive nitrous and leukocytes, however. Retrospectively, her lactate had been 6. She was HIV positive for the first time. And she had markers of infection and inflammation. Although the ultrasound machine available could not perform many functions, we did manage to obtain the images shown on the screen of a transverse view of the pelvis, showing a large right tubo-ovarian complex with multiple fluid levels. However, there was no free fluid around the complex. So we diagnosed her as a pelvic inflammatory disease grade 3, complicated by HIV, hemodynamic compromise, and a concern for sepsis. However, she did get a formal ultrasound at the referral facility after she was referred in the long run, and we did have differentials for TB pelvis, ovarian torsion, and others, although they were lower on the list. Her initial management was she received fluid resuscitation. We collected blood samples for a septic workup, was connected to a portable monitor, received analgesia and empiric antibiotic cover prior to being sent to a high dependency center with a gynecology team, where she was admitted to a high dependency gynecology ward and received a 7-day IV antibiotic course of ceftriaxone, gentamicin, and flagyl with continuous analgesia. She did respond to fluid resuscitation. We saw a serum lactate going from 6 to 0.4, and she had clinical improvement within 72 hours, where she was switched to oral antibiotics on day 8. The team did do further workup for the patient for tumor markers and a complete sexual workup. And we did advocate for her to get a sexual partner tracing and treatment to eradicate the infection. And she was appointed to be followed up after discharge. The take-home points from this presentation or this case are that there are preventable emergencies that present to the ED, and these are linked to limited access to resources and community education in low socioeconomic communities. While successful in this case, it is difficult to manage critically ill patients in a center without basic emergency care services, such as blood gas analyzer and radiological services. However, it does show that honing history taking and clinical examination skills with the available resources often leads to positive clinical outcomes in acute care. Therefore, advocacy for provision of equitable and basic healthcare services in low socioeconomic areas is paramount. Thank you so much for listening. That was the rest of my presentation, and these were my references. Thank you.
Next will be Dr. Baptiste from South Africa.
Good day, I'm Annika Baptiste, presenting on behalf of the Emergency Department of Kalafong Provincial Tertiary Hospital and the University of Pretoria, South Africa. This case explores a rare but life-threatening cause of obstructive shock in the trauma population, underscoring the importance of diagnostic agility in resource-limited emergency care. I have no conflicts of interest to declare, and this case is presented with ethical and academic integrity. The patient was a 26-year-old previously healthy male who sustained high-velocity blunt trauma following ejection as an unrestrained driver. Pre-hospital providers performed rapid sequence intubation on scene due to concern for traumatic brain injury in the context of extensive craniofacial trauma. Upon arrival to the emergency department, he exhibited signs of circulatory shock with a shock index greater than 1, peripheral cyanosis despite mechanical ventilation, and extensive subcutaneous emphysema. Clinical examination revealed equal bilateral air entry with no evidence of rib fractures, abdominal distension, or musculoskeletal instability. Arterial blood gas analysis demonstrated mixed acidosis, hyperlactemia, and a PF ratio indicative of severe ARDS. The initial diagnosis focused both on hemorrhagic and obstructive causes of shock, including tension pneumothorax, cardiac tamponade, and intra-abdominal hemorrhage. Point-of-care ultrasound revealed preserved bilateral lung sliding, and this was confirmed using an adjusted lateral displacement technique, effectively excluding tension pneumothorax. No evidence of hemothorax or intra-abdominal free fluid was identified, further ruling out massive hemorrhage as a cause of shock. Despite these reassuring findings, the patient remained persistently hypertensive, and this prompted the need for a broader diagnostic consideration. Fluid resuscitation was continued under point-of-care ultrasound guidance in conjunction with ongoing pre-hospital inotropic support and while awaiting access to blood products for a massive transfusion protocol. Lung protective ventilation strategies were employed, and simultaneously neurocritical care management was initiated. The chest radiograph demonstrated mediastinal free air, including a linear lucency along the left cardiac border and the classic Nucleario V sign, a V-shaped air collection created by gas outlining the left lower mediastinal margin and extending between the parietal pleura and the mediastinal left hemidiaphragm. These findings reinforced our suspicion of a pneumomediastinum as a rare but significant cause of obstructive shock and prompted urgent advanced imaging. A CT scan was subsequently performed, and this confirmed our suspicion for a tension pneumomediastinum. As we're watching through the clip, note that there's air tracking through the anterior cervical soft tissue planes, extending down into the anterior soft tissues of the abdomen. There's a large collection of air in the mediastinal space, causing posterior displacement of the mediastinal structures with significant right ventricular compression. Posterior lung opacity suggested pulmonary contusions or aspiration, and tracheobronchial injury was suspected as the source of the air leak. A CT brain confirmed extensive craniofacial trauma, including orbital, skull base, and frontal bone fractures. This was further associated with a subdural hemorrhage, a subarachnoid hemorrhage, and extensive cerebral edema. Without access to cardiothoracic surgery or interventional radiology at our facility, we performed a subxiphoid decompression using a central venous catheter. This was inserted via the xiphisternal junction using the Seldinger technique and connected it to an improvised underwater seal. This resulted in immediate hemodynamic improvement. The catheter placement was further confirmed with a formal ultrasound, and the patient was subsequently weaned off inotropes, admitted into the intensive care unit, and ultimately discharged to long-term neurorehabilitation. This case highlights tension pneumomediastinum as a rare but critical and often under-recognized cause of obstructive shock. In resource-constrained settings where advanced imaging may not be readily available, clinicians must maintain a flexible and dynamic diagnostic mindset, taking decisive actions even in austere environments. Importantly, when shock proves unresponsive to both fluids and inotropic support, a cognitive diagnostic checkpoint must be triggered, prompting consideration of alternative and less obvious obstructive causes, including mediastinal pathology. In global emergency care, lives are saved not only by equipment, but by reasoning, readiness, and the courage to act when the time is critical. These references support the clinical reasoning and diagnostic frameworks applied in this case. Thank you.
Next will be Dr. Feddersen from Chile.
Hi, my name is Alexandra Feddersen. I'm a first-year emergency medicine resident at Universidad Austral de Chile, and today I will be presenting a clinical case titled "A Warm Night, a Silent Killer, Hidden Carbon Monoxide Poisoning at Home." To begin, we have no conflict of interest to declare. We're going to present the case of a 61-year-old woman with a history of type 2 diabetes, dyslipidemia, and the curvane tenosynovitis, and her chronic medications include empagliflozin and metformin, and she was also a non-smoker. She came to the emergency department during the night after waking with a sensation of suffocation and chest pain. She also reported nausea and headache, and her vital signs were normal except for a tachycardia. The initial workup included a complete blood count, cardiac troponin, chest X-ray, and an ACG. All results were normal except for the ACG, which showed sinus tachycardia, poor airway progression, extreme axis deviation, and non-specific intraventricular conduction delays. Except for the new onset tachycardia, these were unchanged compared to a previous ACG taken 2 weeks earlier. And based on all these findings, she was initially diagnosed with unstable angina. After 5 hours of persistent headache and nausea, a more detailed medical history was taken, and the patient mentioned using a brazier to warm her bedroom overnight to the cold weather, and that other family members were experiencing similar symptoms. So these raised our suspicion for a carbon monoxide poisoning. Her carboxyl hemoglobin level was 11.1%, but given the 5-hour delay in sampling and the estimated half-life of carbon monoxide in room air, we could assume that the initial level at admission may have between 20 or 25%. Our final diagnosis was carbon monoxide poisoning, and we treat the patient with high-flow oxygen therapy through a non-rebreather mask and symptomatic management with analgesic. Her symptoms improved within 3 hours and they were resolved, and the patient was discharged home. What made this case particularly important to us is that the patient's symptoms closely mimicked an acute coronary syndrome, which initially led to a misdiagnosis and delayed the appropriate treatment. It also highlights the diagnostic challenge when environmental factors are not immediately evident, and emphasized in the importance of revisiting the patient history when symptoms remain unexplained or persist despite standard treatment. Here are 4 key takeaways from this case. First, always reassess the diagnosis when symptoms do not improve as expected. Second, during winter, ask about hidden sources or environmental risks. Third, remember that pulse oximetry may show normal readings in CO poisoning because it cannot distinguish carboxyhemoglobin from oxyhemoglobin. And finally, maintain a high index of suspicion for carbon monoxide poisoning, especially when symptoms are vague, because that can save life. Thank you for your attention, and we welcome any questions that you may have about the case or about this presentation.
Next is Dr. Munyuwaki from South Africa.
Hello, my name is Dr. Naomi Ndukumunyoki. I'm one of the emergency medicine residents from the University of Cape Town in Cape Town, South Africa. My mentor for this particular case is Professor Sad Larry, and I will be taking us through a peculiar case of neck stiffness. I have no conflicts of interest to disclose about this particular case. So it's a case of an 8-year-old male who was previously well presenting to the emergency department with a 4-day history of neck stiffness. There was no important negative, according to the father, denies any rash, denies any upper respiratory tract infection, no history of travel to malaria endemic areas, no seizures, no trauma, or history of ingestion of any substances or toxins. In terms of well baby and wellness approach for the child, there was a mention of a missed tetanus toxoid booster shot that's meant to be given at 6 years. For his physical examination, his vital signs, he had a tachycardia of 129, a temperature of 37.6 degrees Celsius, which is 99.6 degrees Fahrenheit. He did have a respiratory rate of 20 and a normal blood pressure for age. We did note that he did have a small wound on his left hand that was smeared in soil. So in view of the denial of the history of trauma, we did ask the dad what was happening there, and he mentioned it was part of a traditional practice that was done 3 weeks prior to presentation to the hospital. Additionally, he was in this fixed opistonous position and continued having jerky movements just from observation and anytime there was a noise stimuli. And he did have a lockjaw just from continuous trismus of his masseter muscles with a positive spatula test that I will talk about later. So this is the position he carried on having during the entire period. So it would be on and off, but wasn't quite fit in a seizure picture. So at this point, our differential diagnosis was broad, but common things occur more commonly. So the top of the list was still meningitis. This is a young child that was coming in with neck stiffness anyway. But in view of the continuous jerky movement, the opistonous, the lockjaw, we started entertaining other things that would give him these symptoms. So we thought about hypocalcemia as a possibility, a space-occupying lesion that would be resulting in the symptoms, particularly neurocysticercosis or any other non-benign lesion that would be giving him the symptoms. We did entertain a toxidrome, less likely, and due to vaccinations, we did entertain tetanus in as much as we don't see a lot of tetanus in this day and age. So in terms of his lab findings, normal white blood cells, normal calcium, normal lactate, which wasn't in keeping with a seizure that was ongoing. Because if you're having continuous tonic-clonic movement, you would have like a raised lactate. His CT brain also came back normal. That prompted us to do a lumbar puncture, but the results for that took some time. So at this point, while we had the patient, we opted to approach it as a meningitis. We did treat him with a meningitic dose of ceftriaxone, and he, in view of the lack of his tetanus toxoid booster, the wound that he had on his small finger smeared in soil, and the fact that he had a positive spatula test, which involves introducing a tongue depressor to the back of the throat. If they gag, that's negative. If they bite on it due to continuous spasms of your masseter muscles, then that's a positive test that has 100% specificity for tetanus. So in view of that, we opted to also treat and cover for tetanus. So he was given ceftriaxone meningitic dose. He was also treated with immunoglobulins, tetanus toxoid, and we supportively gave him benzodiazepines, which were to help with the jerking movements that he was continuously having. He was given fluids, and he was also given antipyroxyls. He was admitted to the pediatrics high care unit just to anticipate any respiratory complications that come with tetanus. And he was nursed in a dark room that was silent just to avoid triggering the jerky movements that would come with sound stimuli. This child did extremely well and was discharged from the hospital 3 weeks later. So the take-home message for this particular case was to avoid anchor bias. Yes, common things do occur more commonly, but think of the other thing if the shoe doesn't fit, and also the importance of clinical exams, because at the end of the day, for conditions like tetanus where we don't have specific tests, it's down to your history and your exam findings. Thank you so much for attending my case. Do have a lovely day.
Next will be Dr. Nguyen Lee Cam from Vietnam.
Ladies and gentlemen, today I would like to present a case that highlights the diagnostic challenge of methanol poisoning when it presents atypically, acute bilateral blindness with a preserved consciousness. I would like to show my appreciation with my supervisors, Dr. Phạm Quang Trình and Dr. Nguyễn Ngọc Thanh Tú, also my team member, Dr. Phạm Duy Hoàng, for supporting me to complete this case. So we have a 47 years old male patient with a PMS, smoking and using alcohol for more than 20 years, presented to the hospital due to progressive vision loss in 1 day. 1 day before admission, he experienced an onset bilateral blurred vision without any associated pain or redness. He went to a local hospital for outpatient treatment, but then was no improvement. By the next day, the vision became worse. The patient could not see anything anymore, and he also denied nausea, vomiting, headache, abdominal pain, fever, trauma, seizure, and unexplained weight loss. This was the first time he had this kind of condition. On examination, he was fully conscious with a Glasgow of 15. His vital sign was quite stable, though he had tachycardia and his respiratory a little bit increased. He have more use of accessory respiratory muscle, neurons, neuronchi, no wheezes, and his pupil was mydriasis of 4 millimeters with no live reflex. His fundoscopic examination is unremarkable and other system is not significant. He also has several initial lab tests, as you can see here, the EKG, the echocardiography, and abdominal ultrasound, no abnormal findings. His urea was a little bit high, the potassium was 5.5, the CRP was 50, and the white blood cell in CBC was a little bit increased, which was predominant with the neutrophil. We also indicate for him some CT scan contrast, and then nothing abnormal finding. So we decided to give him an MRI to look for some lesion which cannot exist in early stage. So you can see here, he have the restrict diffusion lesion of the bilateral basal ganglia with increased signal on flare and no signal drop on T2, and it was suspected due to metabolic causes. So we indicate for him an ABG, and this is the results. It revealed a severe high anion gap metabolic acidosis with the anion gap was 31. We cannot measure the osmolar gap in this patient. However, combined with the clinical manifestation, this patient had the mydriasis and the PMS using alcohol for more than 20 years. According to the mud point, we exclude all of other causes, so most likely in this patient was the methanol intoxication. We give him some diagnostic tests. The ethanol was undetectable and the serum methanol was 38.97, so he was diagnosed with methanol intoxication. So he was management with the supportive care combined with the CRT and the ethanol therapy to antidote to the methanol poisoning. After 10 days, he showed a progressive improvement in the systemic status. However, he had the permanent visual impairment was noted, consistent with the irreversible methanol-induced optic neuropathy. And this is the amount of the alcohol that used for him. So in Vietnam, methanol poisoning is quite common due to the control norm of the frequent social drinking and extensive consumption of unregulated alcoholic beverage among adults. So with methanol and ethanol is quite transparent and colorless, so there is almost no difference in taste and odor, so it is quite difficult for us to tell them apart. However, the most obvious symptom is visual impairment, which is clearest clinical distinction between patients who are just drunk and those with a methadone poisoning. I also found some case report about the vision loss due to methadone intoxication, and in resource limited settings such as documented experience from Vietnam's National Poisoning Control Center, we can suspect with the methadone intoxication in the patient have at least two of the following criteria: the history of daily alcohol use with acute intoxication, signs of metabolic acidosis, and visual disturbance such as blurred vision or blindness. So this is my typical methods. Initial symptoms of methadone poisoning may include the acute vision loss or blurred vision, sometimes without headache or enter consciousness, which can lead to the misdiagnosis if not carefully considered. The blood methadone testing confirms the diagnosis, but often takes time. Therefore, clinical symptoms and blood gut analysis should guide early treatment. And never fully trust patients with PMS of alcohol addiction when they say they haven't had any alcohol. Thank you for listening.
This will be our last presentation prior to our intermission for 10 minutes. This is from Dr. Fogel from South Africa.
Hello everyone, and thank you for being here today. I'm Dr. Emily Fogel, an emergency medicine registrar based in Cape Town, South Africa at the University of Stellenbosch. Today, I'll be presenting a case of pediatric organophosphate poisoning that was highly unusual, presenting not with the usual cholinergic crisis, but with a rare nicotinic predominant neurological syndrome. Pesticide poisoning remains a critical public health issue in South Africa. Here, so-called street pesticides are cheap, easily accessible, and used widely across informal settlements. The headlines you see aren't isolated events. They reflect a pattern, one that's deadly, under-recognized, and frequently faced in our emergency centers. Street pesticides refer to illegally compounded agricultural pesticides that are unregulated. They are found freely, often in unlabeled bottles, easily mistaken for juice and milk. They are sold in spaza shops within townships for use in homes for rodent and insect control. Children are especially vulnerable, and these toxins are often accidentally ingested. We present the case of a 4-year-old girl who ingested one of these pesticides. A previously healthy 4-year-old girl presented to a rural emergency center after the ingestion of a cattle pesticide, known locally as DIP, that had been stored in a juice bottle. Before arrival, her parents reported some vomiting, some abdominal pain, as well as slurred speech. But on arrival, she looked well. She was alert, all vitals were in normal range, and she had no signs of classic cholinergic toxicity. Specifically, no meiosis, no secretions, no bradycardia. But within the next hour, she deteriorated. She became weak and lethargic. Facial fasciculations and hypersalivation were seen, but no other muscarinic signs. Limited investigations were available in this rural setting, but her blood cells showed hypokalemia and profound hypocalcemia. Given the exposure history, a working diagnosis of organophosphate poisoning was made. She received a stat dose of atropine, which cleared her secretions, and a dose of IV calcium, and was transferred promptly to a tertiary pediatric center to me. On arrival, I found her lethargic. She had a low-grade fever, but still without respiratory distress or excess secretions. Over the next hour, her symptoms evolved and things started to get wobbly, quite literally. She developed generalized fasciculations, multifocal myoclonus, and ocular clonus, with a global increase in tone and profound ataxia. Meiosis did eventually appear, but notably still in the absence of other muscarinic features. This was not the classic toxidrome we've been taught. Instead, it was a nicotinic-driven neurological syndrome, one that closely mimicked a primary CNS disorder. She was observed closely for 36 hours, and there was no need for further atropine. And she made a full neurological recovery. Her serum pseudocholinesterase came back very low, which supported our suspicion of organophosphate poisoning. The case was notified for surveillance purposes, and the substance was sent for analysis, and I'm still eagerly awaiting the exact result. So, what makes this case unique, and what can we learn? Pediatric organophosphate poisoning often presents with central and nicotinic signs rather than classic muscarinic features. The child's opsoclonus, myoclonus, and ataxia represent a rare, likely under-recognized manifestation of organophosphate toxicity. Clinical suspicion, context, and a bit of detective work will always make the difference. Without the exposure history and input from the caregivers, this case could have easily been missed. Street pesticides represent a public health crisis in South Africa. They are highly variable in composition, resulting in unpredictable presentations. They contribute to frequent and often unrecognized exposures, particularly among children. There is a significant gap in antidote accessibility. Whilst atropine was appropriately used, oximes like palidoxime, which is potentially helpful for nicotinic symptoms, remain unavailable in South Africa's public sector due to expense. Despite ongoing debate about their role, the lack of access limits treatment options for a commonly seen toxin in our setting. Finally, this case reminds us that in emergency medicine, we need a clinical mindset that is flexible and inquisitive, as organophosphate toxicity, especially in kids, may not always follow textbook presentations. We must remember to ask about exposures, involve caregivers early, and stay alert to atypical or evolving neurological presentations, especially in children. In conclusion, in our setting, toxin exposure must remain high on the differential for every pediatric neurological presentation. Thank you so much for listening, and please feel free to reach out on this email.
Wow, fantastic. A huge congratulations to the first 10 abstracts that we've gone through today. We have spanned everything from tension pneumomediastinum to carbon monoxide poisoning, from tetanus to cerebral malaria. This is truly what makes emergency medicine exciting, and I'm very biased, obviously, but the best specialty in the world. So thank you again so much to all of the first 10 presenters. You've done a lot of work. And we're looking forward to then the next 10 after the intermission. So right now we will have a 10 minutes break. I'm not going to give an exact time because I know we're all in different time zones around the world. So 10 minutes from now, we will reconvene to listen to the next 10 abstracts for the competition. Just as a quick reminder, please do stay on through the end of the competition, because there will be a People's Choice Award at the end, and we want everyone to vote for your favorite presentation. So stay tuned in 10 minutes for the next 10 abstracts to be presented. And then at the very end, we will have the announcement of the awards, including the People's Choice Awards. So please stay on board. All right, enjoy the break, and we will see you back in 10 minutes.
Okay, we will be resuming with our last 10 cases now that the intermission has finished. We will be starting with Dr. Khoi Tran Pham from Vietnam.
Warmly welcome, my beloved colleagues. My name is Trần Phạm Minh Khôi, third year pediatric resident at Penn University of Vietnam, and it's my honor to share with you an interesting case that I and my mentors have met at our hospital. Now let's start. A previously healthy 11-year-old boy presented to our hospital due to cyanosis of the right third finger. The day before admission, he had a tiny open wound at the finger caused by a thin spine puncture of a dirty dead jawfish and progressive pain. He kept playing without proper wound hygiene, and in the next day, the injured finger became cyanotic and extremely painful, as picture showed here. Patient got high fever and was admitted to a nearby hospital. Here, the diagnosis was cellulitis, and he was treated with wound care, antibiotic, serum tetanus antibody, The pain decreased after wound puncture and the patient was transferred to our hospital. On admission, the significant feature was the cyanotic finger, as picture showed here. You can see the finger was hot, swelling, the distal and middle phalanges were cyanotic, loss of sensation, poor movement, some discharge in wound, and patient was really painful. Lab test showed leukocytosis with neutrophil majority and high CRP level, normal coagulation, and no abnormality of big arteries and their accompanying deep veins found on Doppler ultrasound. Diagnosis was compartment syndrome and necrotizing cellulitis. We also consider thrombosis and toxicity from the fish fin or invaded pathogen. He was immediately treated with emergency fasciotomy and combination antibiotics. Then, only ciprofloxacin was continued due to suspected pathogen was Vibrio vernificus. Fever stopped at the second day of admission. The pain and inflammatory markers reduced, and patient got discharged after 13 days. Through the case, I want to share with you some points. First, compartment syndrome is the condition of increasing pressure within an enclosed fascia space, and infection is one of the causes. Diagnosing mostly based on clinical feature of 5 Ps as showing here. An emergency fasciotomy is an urgent necessary treatment. Expeditious intervention often result in full functional recovery. About the causality, jodfish is a harmless species to human. Distribution among Mekong Basin. It lives in freshwater, demersal tropical region. Turning to Vibrio vernificus, it is a gram-negative bacterium, and despite the rare pathogen, it can cause high fatality rate up to 50%. Transmission via consumption of contaminated fish or shellfish, and skin exposure to contaminated warm seawater. Very clinical manifestation, and skin or soft tissue infection is just one of these. Empirical antibiotics are listed here, and surgery can also be done to remove necrotic tissue and bacteria. In conclusion, the most likely diagnosis of our patient was compartment, although finger compartment is rare. Promptly emergency fasciotomy and suitable empirical antibiotic contributed to successful recovery of patient. Secondly, poor wound hygiene led to enormous problem. Starting with a tiny wound, it rapidly progressed, resulting in necrosis of the finger. Hence, wound hygiene is really important in preventing from serious complication. These are some take-home points of the case. Wound hygiene is vital, even a tiny lesion. Compartment syndrome required emergency fasciotomy to avoid complication. Bacterial spectrum is critical in choosing empirical antibiotic, and raising public awareness regarding the initial wound management is really essential. This is the end of my presentation, and thank you for your attention.
Next up is Dr. Sepulveda from Mexico.
Hi everyone, my name is Jimena Sepulveda. I'm an international medical graduate from Mexico, and today I'm going to be telling you a compelling, interesting case study that we had at the hospital named Innovative Management of Complex Abdominal Trauma in a Resource-Limited Setting, a case of adaptive emergency care. For a patient's background, he was an 18-year-old male that went to a party and was assaulted. He revealed on physical examination hypotension, tachycardia, diminished peripheral pulses, and diffuse abdominal tenderness on GERD. On the laboratory findings, on the beginning, there was leukocytosis, anemia, thrombocytopenia, elevated liver enzymes, low creatinine, and others. So the initial assessment that we had to do on the ER, first thing was check the patient's status, his vital signs, the Glasgow score, the peripheral pulses, and based on that, on the physical examination that we did, revealed that the patient was clinically unstable and there were signs of acute abdomen. Adding to it, the laboratory findings revealed that the patient was in a trauma-induced hypercatabolism and we couldn't wait. So we took the patient immediately for an exploratory laparotomy because there was lack of advanced imaging, and we did IV fluids and blood transfusion on our patient. The patient's journey was complex. So he was first assaulted and sustained a thoracoabdominal trauma, and he came to our hospital with signs of acute abdomen 10 days after the trauma. The first thing we did was the exploratory laparotomy that I just mentioned. And after the first surgery, he presented with signs of septic shock and anastomotic dehiscence and fecal peritonitis. After that, the surgical case just got very complicated for a patient. He required 11 surgical interventions in 46 days, including washouts, bowel resections, using a Bogota bag. He also had the complication of a pancreatic fistula that was initially managed with octreotide. And then on day 50, he was finally discharged with stable nutritional status and a functional bowel. Because of the limited resources we had at the public hospital in Mexico, we had to adapt to what we had. So based on the hemodynamic instability and peritoneal signs, and because of the lack of advanced imaging, we took the patient for an exploratory laparotomy. We also use a Bogota bag, that the utility of it is allowing abdominal expansion, prevent the disseration and contamination, to visually access the abdominal cavity, and to reaccess for ongoing surgeries. This is just a representative imaging of Bogota bag. Other of the resources that we use was a biochemical diagnosis of a drainage that demonstrated very, very high amylase and lipase that helped us confirm what we suspected of a pancreatic fistula, because the simple CT scan was inconclusive. We could actually finally get the patient on an ERCP 16 days later, and this is the pancreatic fistula on the ERCP. And because we had to wait so much to completely diagnose the pancreatic fistula on the ERCP, we had to manage the pancreatic fistula in another manner. So we used octreotide. But actually the medication was not available in the hospital, so the family of the patient had to obtain it elsewhere. Based on this, the teaching points basically are how to adapt and be resourceful to what we had on a public hospital in Mexico. The use of a Bogota bag as an effective low-cost tool for abdominal closure, how a biochemical analysis helped diagnose the fistula, and the family engagement helped us overcome the therapeutic barriers. In conclusion, this case illustrates how innovation and adaptability helped us overcome this case, how the clinical decision-making, fast-acting, teamwork in the ER, and then with all the other doctors helped enable success in this patient. And it highlights the importance of global emergency medicine in an underserved setting. Thank you so much for your time.
Next is Dr. Popula from Nigeria.
Good day, everyone. My name is Akimbade Popola. I'm an emergency and critical care doctor from the Emergency Healthcare Consultants of Nigeria. I'll be presenting a rare case of spontaneous pneumothorax known as Catamenial pneumothorax. This case was managed by a multidisciplinary team, and I acknowledge the contribution from my colleagues listed in the slides. I have no financial conflict of interest to disclose, and the management of this case was undertaken by the full medical team. I present a 35-year-old nulliparous woman who came to the emergency department with complaints of chest tightness, dizziness on exertion, and dizziness of 3 days duration. Symptoms started 2 days prior to her menses. Her past medical history was significant for myomectomy, which she had 4 years prior. Vital signs were stable. Physical examination showed reduced breath sounds in the right hemithorax. Her laboratory investigations was essentially normal. However, chest X-ray reported right-sided pneumothorax with compressive atelectasis and mild mediastinal shift to the left. If you take a look at this chest X-ray, as you can see that there's reduced lung marking in the entire right lung zone, and the right lung is pulled towards the hilum. She had a diagnosis of catamenial pneumothorax. Management included a chest tube insertion to the right side with physiotherapy and intensive spirometry, and a follow-up X-ray reported lung re-expansion with resolution of the pneumothorax. Surgery was offered, but she declined it, and she was discharged to the cardiothoracic surgery and gynecology clinic. She presented at the beginning of her next menstrual period with similar symptoms. Physical examination showed absent breath sounds in the right hemithorax. Her vital signs showed tachycardia, tachypnea, and suboptimal saturation of oxygen in room air. Laboratory investigations were essentially normal. However, her chest X-ray reported right tension pneumothorax, evident in this image by deviation of the trachea to the left side and also the mediastinum to the left side. She had a right chest tube insertion and a video-assisted thoracoscopy surgery, which is a minimally invasive procedure in which 2 diaphragmatic perforations were found with multiple endometrial tissue, which was later confirmed with histology. Diaphragmatic repair and mechanical periodicis was done. Post-operatively, with physiotherapy and intensive spirometry, there was spontaneous resolution of the pneumothorax as evident in this imaging. Patient was discharged a few days later, and hormonal therapy was deferred due as patient desired conception. Patient has been symptoms-free 6 months post-procedure. So my learning points. Catamenial pneumothorax is a rare form of spontaneous pneumothorax that is linked to thoracic endometriosis. Typically occurs in women of reproductive age group, and it makes up for 1/3 of spontaneous pneumothorax. It typically occurs within 72 hours before or after menstruation. Data is limited in Nigeria, but a study found catamenial pneumothorax in about 21% of patients with thoracic endometriosis, which is suggestive of under-recognition. Tension pneumothorax is a rare but serious complication that necessitates urgent management. Early recognition and multidisciplinary management are essential to improve outcomes and prevent recurrence. Here are my references for further reading on catamenial pneumothorax. Thanks so much for listening, and I'm here to take questions.
Next is Dr. Mutsikira from South Africa.
Good day. My name is Dr. Heather Rosalind Mutsikira from Tambo Memorial Hospital in Johannesburg, South Africa. I'm presenting Navigating the Management of a Cholinergic Toxidrome in a Resource-Limited Setting. The authors declared that they have no financial or personal relationships that may have inappropriately influenced them in writing this article. I'm presenting a 39-year-old male patient who presented to a private hospital, collapsed after drinking with some friends, reported to have been vomiting and having diarrhea at home. On examination, he is noted to have reduced consciousness, fasciculations all over, pinpoint pupils, and secretions. His vitals showed an elevated blood pressure, with low sats of 25% on room A. Unfortunately, they were missing vitals in the referral letter, and communication during the referral was suboptimal. At the private hospital, patient was resuscitated, intubated and ventilated, started on atropine boluses up to 30 milligram total incremental dose. Pyridoxine was unavailable. Patient also received midazolam 5 milligrams. Due to financial constraints, patient was transferred. At the public hospital, patient was connected to a ventilator in the emergency department. GCS was noted to be 6T on 10. Pupils were 2 millimeters bilaterally. BP had normalized. The patient had a tachycardia and SATs were 95% on the ventilator. Venous blood gas was repeated and patient was still in respiratory acidosis. He was initiated on atropine infusion at 3 milligrams an hour. Pyridoxine was also unavailable at the public hospital. Mechanical ventilation was continued in the ED as there were no beds to transfer the patient to ICU. Patient was extubated after 2 days while still in the emergency department. Atropine was weaned and stopped over 4 days. Patient was eventually transferred to the ward and discharged on day 10. This case highlights systemic challenges that stem from a two-tiered health system with an underfunded public sector. Organophosphate poisoning remains a significant public health challenge in many developing countries. These compounds are readily accessible within communities as they are widely marketed at a low cost for agricultural and domestic pest control. Diagnosis is primarily clinical, based on characteristic muscarinic and nicotinic signs. Laboratory investigations to confirm exposure are often unavailable. Management typically requires airway support, the administration of large doses of atropine, and prolonged hospitalization, placing a considerable burden on underfunded public health systems. The absence of alternative antidotes, such as oximes, further limits effective treatment and contributes to complexity of care and limits therapeutic options. According to a 2022 World Health Organization report, South Africa was ranked as the most unequal country globally, a disparity driven by high levels of unemployment, limited access to quality education, and enduring socioeconomic consequences of apartheid. This inequality is clearly reflected in the country's two-tiered healthcare system. The public sector, which is government-funded, caters to the majority of up to 80% of the population. It remains severely under-resourced, characterized by staff shortages, frequent medication stockouts, prolonged waiting times for specialist consultations, and delayed access to surgical interventions. In contrast, private sector is better resourced, with more efficient service delivery and reduced waiting times. But it remains accessible primarily to those who can afford medical insurance or out-of-pocket payments. This case shows the challenges posed by a tiered healthcare system, where an inefficient public sector is compounded by poor coordination with the private sector. I present to you the references for the information on the slide. Thank you.
Next will be Dr. Kamomisa from Ghana.
Let's go on an interesting journey to unravel a medical mystery I encountered. My name is Tefaria Bakum Emisa of the Kolebu Teaching Hospital, Ghana, presenting on dissecting a diagnosis, a missed aortic dissection masquerading as an acute coronary syndrome. I present a 48-year-old hypertensive woman who was referred to our facility with a presumptive diagnosis of an NSTEMI, following a 3-day history of acute severe dull central chest pain radiating to the back and was worsened by inspiration. The pain was rated 8 out of 10 and was associated with 4 episodes of non-bilous, non-bloody vomiting. Initial examination revealed a tachypnic but alert patient with normal oxygen saturation of 97% on room air, had clear lung fills, and an unremarkable cardiac auscultation. Notably, there was a marked inter-arm systolic blood pressure difference of 43 and a pulse volume disparity as well. An ECG done showed sinus tachycardia, signs of left ventricular hypertrophy, and lateral ST segment depression, raising suspicion for a hypertensive heart disease. Incidentally, a bedside ultrasound scan done picked up an intimal flap in the descending aorta. This image is showing a longitudinal view of the abdominal aorta, showing the intimal flap as seen here. This is also a transverse view of the abdominal aorta, showing the intimal flap as seen. So our working diagnosis was acute chest pain with the differentials of 1, aortic dissection. We had a high index of suspicion for this because patient had central chest pain radiating to the back, had a significant interarm systolic blood pressure difference, had pulse volume disparity, and had a risk factor of hypertension. Our second diagnosis was acute coronary syndrome. Due to the fact that we had a high index of suspicion for the aortic dissection, we ordered a CT aortogram, which revealed a Stanford B aortic dissection, demonstrating 1 true and 2 false lumens, extending into the descending aorta with associated periaortic and left pleural hematoma. Patient was managed conservatively by the physician team with intravenous labetalol, titrated to achieve a target systolic BP of 120 and a heart rate of 60 beats per minute, alongside analgesia with morphine. She remained hemodynamically stable throughout her 11-day stay in the hospital and was discharged with follow-up plans under vascular surgery. This is a CT aortogram that was done for her, indicating the dissecting flap as seen here in the descending aorta. So aortic dissection is a rare condition, but it's a life-threatening condition which occurs after a tear in the intima allows blood to enter the media and dissects between the intimal and adventitial layers. One needs a high index of suspicion for its rapid recognition and intervention to reduce unfavorable outcomes because mortality rate can increase to 1 to 2% per hour after symptom onset and can go as high as more than 50% after 24 hours of onset. Now, this condition poses a diagnostic challenge due to its variability in clinical presentation and has non-specific symptoms and can mimic other clinical conditions such as acute coronary syndrome and pulmonary embolism. Now, this case goes on to highlight the pivotal role of thorough clinical evaluation, which involves a comprehensive history taking, detailed risk factor profile to help pick up patients at risk for this, and then a thorough clinical examination. Now, one needs to maintain a high index of suspicion for such patients, especially those with atypical or subtle presentation. This case also goes on to highlight the important role POCUS plays in its management. While CT angiogram is a gold standard for imaging, the use of point-of-care ultrasound is critical, especially for its early identification, especially in hemodynamically unstable patients or where imaging access is limited. Now again, every patient with chest pain must be approached with the consideration of having a potential acute aortic dissection, as prompt identification and timely imaging is crucial to prevent misdiagnosis and also minimize morbidity and mortality. These are my references. This is the end of my presentation. Thank you.
Next is Dr. Ayeni from Ethiopia.
Hello everyone, I am excited to be able to participate in this case competition. I am here to present a case of orbital abscess mimicking tumor, a diagnostic challenge of a pediatric case of retained wooden foreign body. My name is Enoch Ayena. I am a third-year radiology resident. My mentor is Dr. Alamayehu Bedani, who is a body and neuroradiologist. I have no disclosure. Initial presentation, this is a 10-year-old male patient presented with 6 months progressive eye swelling and pain. There was no reported history of trauma, and on examination, the finding was mild axial MRI of the orbit with post-contrast acquisition was performed. You can see we have an axial T2 weighted image showing the presence of orbital lesion in having a fusiform shape and heterogeneously hyperintense T2 signal with MRI of the orbit with post-contrast acquisition was performed and displacement to medially. And you can see the inferior extension and anteriorly into the inferior eyelid. And the post and the pre-contrast T1 coronal T1 spin echo image shows the presence of intermediate signal intensity within the extracorneal compartment and with central hypointense area. And the post-contrast non-PAT-SAT image shows peripheral rim enhancement with central enhancing core, which abuts the optic nerve superiorly. It was initially interpreted as cavernous hemangioma, and the patient was lost to follow-up after the first MRI and was returned after 5 months later with progressive swelling, pain, and purulent sinus tract. And you can see this is an oblique sagittal image of T2 steer image showing the peripheral hypointense rim and predominantly hyperintense lesion and with central hypointensity. And the T2 hyperintensity extends in this axial image into the skin, and there have been this periorbital path stranding have been appreciated. And the pre and post contrast T1 image of this coronal sequence shows intermediate T1 signal abnormality with central hypointensity. And the post contrast shows rim enhancement with central enhancing core with adjacent inflammatory stranding. With this presence of orbital abscess and suspicion of this non-enhancing core in all sequences as a foreign body, the diagnosis of foreign body was made, and patient underwent orbital exploration and wooden chip removed through the inferior eyelid wound, and systemic antibiotics was administered, and the post-op recovery was smooth, and the visual acuity was in normal range. Histopathology confirms the presence of plant material. There was no fungal element. You can see this is a comparison image between the initial and repeated MRI, showing there is no much difference in those post-contrast image, showing this rim enhancement of the lesion. Slight decrement in size may be attributable to the presence of abscess drainage into the skin. This is a post-op image showing the presence of these foreign bodies which were removed from the patient orbit. So coming to the discussion, why was it missed in our case? It's because of we don't have any trauma history, which makes us for suspicion of low suspicion in foreign body, and absence of DWI in ADC was not performed, which will ease our diagnosis in suggesting the presence of central restriction, which will suggest will abscess, and within foreign body MRI features will have hypointensity on all spin sequence like air. So, and they will have also T2 hypointense rim, like fibrosis surrounding the lesion. And the modality of choice is usually CT, thin slice with variable window. But if it's missed on the CT, you can go for MRI, but MRI can miss also this case. So having this radiologic feature for radiologists is very important. You can see this is a companion case, which I have seen from the RSNA. You can see it on the superior quadrant of the orbit, we have a hyperintense lesion with central hypointensity, and the post-contrast image shows rim enhancement with central enhancing component. This was confirmed to be an orbital foreign body with abscess. So the thinking point is pediatric patients may not recall or report minor trauma. They may not present with visible entry wound. So presence of recurrent orbital infection despite treatment, presence of fistula or non-resolving swelling. In that case, we have to consider foreign body as a differential. Everything foreign body can mimic tumors, like in our case, like chronic abscess can also mimic tumors, like hemangioma. And presence of signal void in all sequences and presence of this rim enhancement surrounding the signal void and with sinus tract will suggest the presence of foreign body with abscess formation. Follow-up is very critical, so we have to be vigilant to have a follow-up image, and the references are this. So thank you.
Next is Dr. Lam from Vietnam.
Good day, everyone. My name is Lê Vũ Thùng Lâm. I'm the pediatric resident at the Vin University. Today, I will present a case that emphasizes the potentially overlooked the cause of cardiac arrest in children, which could be challenging to diagnosis due to non-specific symptoms. I have the 9-year-old girl who was previously healthy, brought into our ER after experiencing a sudden cardiac arrest. Over the past 2 days at home, she had a history of non-productive cough and intermittent wheezing. The family member denied any symptom like fever, running nose, and choking. On the day of admission, she had one prolonged coughing episode followed by cyanosis. During transferring to local hospitals, she suddenly had a cardiac arrest. Then she was intubated and taken the brain CT scan, which is normal, and she was transferred to our hospital. About her past medical history, that was not, that is unremarkable. The child did not take recently any medication. There was no allergy to food or any medication. The development was normal. The family members are healthy, and no one had cardiac arrest before or sudden death. About the physical examination at the ER, there were remarks for only degree air movement in the left lung. The lung sounds were clear. And about her focus, the hearts were in good contraction, no pericardial effusion. The IVC was mild collapse. There was no pneumothorax. About the laboratory investigation, we taken the 5S5D algorithm to investigate the cause of cardiac arrest in these children. The only marker that might elevate is the troponin E is 0.1, and the other investigation was normal. This is my differential diagnosis, which is 5S5D. The hypovolemia is less likely thing because the child, there was no sign of dehydration in this children. The electrolyte was normal. Her temperature was normal. The blood gas admission was ankylosis. The PS was 7.5. There was no pneumothorax or cardiac tamponade in the focus, and the toxin was unlikely thinned up because there was no history of taking unusual drug in this patient. Did her chest X-ray at the admission, you can see that there was total collapse in the left lung, and we immediately think about the aspiration of foreign body in this patient due to the past medical history. So we perform the emergency bronchoscopy, and this is her chest X-ray after the bronchoscopy. This is her foreign body, which was taken in the left bronchus. About the follow-up, the child was stable after 24 hours and made a fully recover, and she was discharged 24 hours after the ICU. This is my take-home message. The diagnosis of foreign body aspiration could be challenging, particularly in the absence of the clear history of choking, like this patient. And the children with lower airway foreign body may present with subtle or non-specific symptoms like dyspnea, wheezing, chronic cough, or recurrent pneumonia. And in this patient, a cardiac arrest. The 5S5D algorithm should be employed to systematically investigate the potential cause of cardiac arrest in older pediatric patients. Thank you for attention.
Next is Dr. Tu Dang from Vietnam.
Good morning, everyone. My name is Chang Dang, and today, on behalf of Pratten and Yifat, who are co-authors, I am presenting a case titled No Respector, No Clues, Still Pulmonary Embolism, a case study in the typical presentations. This case explores how life-threatening conditions can hide in plain sight. This report is for educational purposes only. Patient identifiers have been removed, informed consent was obtained, no conflicts of interest declared. Our case begins with a 63-year-old female with no significant past medical history. The evening before admission, she experienced a sudden severe left-sided chest tightness with a sense of impending doom that lasted around 20 minutes. Later, the pain reduced to a constant and dual ache. The following morning, the same crushing pain returned while she was walking down the stairs, causing her to collapse without syncope or head injury. She was first evaluated at a local hospital, where provisional diagnosis of non-STEMI was made, but no treatment was started. She then requested transfer to our emergency department, arriving in the third hour of her chest pain. On arrival, her ABCDE assessment was largely unremarkable, except her vitals showed tachycardia 110 beats per minute, blood pressure of 103/72, with an oxygen saturation of 98% on room air. Given the patient's age and certain intense chest pain, combined with an ECG finding no SA elevations, acute coronary syndrome, specifically non-STEMI, was high on our differentials, while PE remained low probability based on the Wells criteria at that moment. In addition, her labs were concerning. Troponin T was significantly elevated. The dimer was not ordered initially, regarding a very low chance of PE based on clinical judgment and pre-test probability. At this point, it looked like classic heart attack, but the picture was about to change when we found the abnormality in echocardiography. Bedside TTE revealed right ventricular dilations and dysfunctions with elevated pulmonary artery pressure. These findings are not typical for primary cardiac events, but are highly suggestive of right ventricular strain. As a result, pulmonary embolism will increase to intermediate to high probability since the dimer results would take as long as CTPA. We proceeded directly to imaging, which confirmed bilateral segmental pulmonary emboli. She was promptly transferred to the cardiovascular ICU and started on systemic thrombolysis with TPA and heparin. Her treatment course was favorable. Troponin T levels declined and symptoms improved, ruling out non-STEMI. 2 days later, she developed leg swelling, likely from thrombus mobilizations, which resolved over the following week. She was discharged on dual anticoagulations. So, how did we almost miss this? This case is a powerful reminder that PE can present without any classic risk factors. According to research cited in the ESC Guideline 2019, up to 14% of patients with PE have no predisposing factors. Therefore, when presenting with chest pain, a common presentation is masterfully mimic non-STEMI, create a significant diagnostic challenge. This is a critical point for any busy emergency department. In high-volume setting like ours in Vietnam, we must maintain high clinical vigilance. Our initial Wells score was low, but the case demonstrates that in low-risk patients, tools like the PERC rule-out criteria can be valuable to identify which patients still need further investigations in terms of PE. Elevated troponin, which initially pointed us toward ACS, was a red herring, actually reflecting right ventricular strain from a massive PE. And this brings us to our most important point, the role of rapid accessible diagnostics. The bedside echocardiography was a game changer here. It was fast, non-invasive, and immediately shifted our focus. A meta-analysis research in 2017 concludes that studies suggest it is potentially an adequate rule-in test at the bedside in critical care settings, such as the emergency department for patients with a suspicions of PE. While the dimer is great for ruling out PE in low-risk patients, this case proves that for definitive diagnosis and to understand the clot burden of PE in case of intermediate to high probability, CTPA remains indispensable. This is our references, and thank you so much for your listening.
Next is Dr. Baron Cervantes from Mexico.
Good morning. My name is Dr. Natalia Baron, and today I will be presenting a case report about a delayed jejunal-gastric intussusception in a patient after a pylorus preserving pancreatic duodenectomy, which is a rare surgical emergency in oncological patients. First of all, I really wanted to thank my mentor, Dr. Carlos Chan, my team, and my hospital, Hospital Médica Sur, for allowing me to be here. We present the case report of a 60-year-old Latin American male patient who presented to the emergency department. As relevant past medical history, on 2021, he underwent a PPPD for a distal cholangiocarcinoma. After surgery, he underwent 6 cycles of chemotherapy based on gemcitabine, campecitabine, oxaliplatin, and irinotecan. On 2022, he underwent his last surveillance with a PET-CT scan, which showed no evidence of recurrence. However, on early 2023, he presented to the emergency department with epigastric pain, nausea, vomiting, and hematochezia. Upon physical examination, the patient was hemodynamically stable. However, the abdomen was markedly distended and tender, and a palpable mass was shown in the epigastric and left hypochondric regions. Initial laboratories showed an increase in the inflammatory markers as C-reactive protein and procalcitonin were elevated, and as well hyperglycemia. The rest of the laboratories were within normal limits, including lactate. Because of this, the decision was made to perform an abdominal CT scan. Here we have the abdominal CT scan. As you can see on figure A, we have a sagittal view, and in figure B, we have a coronal view of the abdomen. Marked with a red circle, we can see a jejunogastric anastomosis that is being inside of the stomach. Because of this, the initial stabilization of the patient was performed at the emergency department with a nasogastric decompression which yielded bile-stained fluid. Also, IV therapy was started with IV ertapenem, tramadol, and acetaminophen. After the initial stabilization of the patient was moved to the OR for an emergency laparotomy. Inside the OR, we were able to see that the efferent loop of the jejunum, which is marked as A, was invaginated into the stomach, which is marked as B, through the gastrojejunal anastomosis. The initial Hutchinson maneuver wasn't able to be performed because there was a lot of edema in the tissue. Because of this, the decision to perform a gastrostomy and a transgastric reduction was performed. Here we have the view from the transgastric reduction, where we were able to observe 45 centimeters of necrotic jejunum, as you can see in the picture. At the same time, we were able to resect this part of the jejunum. Here we have the macroscopic piece after resection. After resection, we were also able to create a reconstruction involving hand-sew end-to-end jejunal anastomosis and a primary wall closure for the gastrostomy. The postoperative recovery of the patient was really uneventful, and he was able to be discharged 5 days post-op without any complication. The most important parts of our case report are, first of all, to emphasize that jejunogastric intussusception is a really rare complication in patients with PPPD. However, this procedure is increasingly being performed for periampular cancer. So, if your patient had this procedure, you need to take care of this. This can occur many years post-op. Our patient was 2 years post-op and was in complete cancer remission, which underscores the importance of considering sequelae in patients with oncological procedures, especially if they come to the emergency department with acute abdomen presentations. At the same time, it's extremely important to emphasize the importance of the role of emergency medicine. Our patient was completely stabilized in the emergency department with the nasogastric decompression, the IV therapy, the imaging studies, and this was crucial for our positive outcome. Finally, if you have a patient with previous reconstructions, we need to consider uncommon complications, which are highly deadly. Prompt identification of these are going to allow you to identify ischemia and prevent further bowel loss. Thank you so much for hearing me today, and I hope you like our case as much as we did.
This will be our last presentation of the day. This is from Dr. Alamu from Ethiopia.
Hello, everyone. Good morning. I'm Dr. Getachew Alam from Ethiopia, an emergency physician. My moderator is Dr. Marai Kafalo. He's an assistant professor from Addis Ababa University, East Africa, Ethiopia. This is a case of widowmaker artery occlusion in young male without risk factor management in resource limited setting. So as a disclosure and acknowledgement, there is no conflict of interest. Informed consent was taken from the patient, and special thanks goes to the Heart Attack Ethiopia, a US-based mission, and the second gratitude goes to my moderator, Dr. Marai Kafalo. The outline of the presentation has an introduction part, case summary, brief discussion, and the take-off message. As an introduction, as all we understand, acute coronary syndrome describes a spectrum of condition caused by acute myocardial infarction. The syndrome encompasses three entities: unstable angina, non-ST segment elevation MI, ST segment elevated myocardial infarction. Often this entity distinguished based on EKG finding and cardiac biomarker, particularly troponin. A widow's maker is also called a warning sign, is a critical proximal LAD stenosis with possible fatal consequence. It's called widow's heart attack because usually it ends up with women with spouseless. It can be associated with extensive acute anterior wall myocardial infarction and LV dysfunction and cardiogenic shock. Usually, it's believed over 50% of individuals with CAD do not have identified risk factor. This suggests the importance of non-traditional risk factors and genetic cause of the disease. Traditional risk factors include diabetes, hypertension, dyslipidemia, and cigarette smoking. Welcome to the case summary. This is a 35-year-old male, Ethiopian taxi driver, father of three with no apparent comorbid medical illness and traditional risk factor. Presented to the emergency room with chest pain of 2-hour duration. The pain was described as squeezing in nature, radiating to the left arm, shoulder, accompanied by easy fatigability, feeling of anxiety, and shortness of breath. His vital sign is the normal range initially, except apparent tachycardia of under 38, and the rest of physical exam is unremarkable. Subsequently, the patient was put on monitor, which shows ST segment elevation on the anteroseptal and lateral lead, and bedside ultrasound also indicates septal and apical hypokinese. This suggests an acute myocardial event, and he was started immediately with medical management. Within 1 hour of the emergency visits, the patient becomes unresponsive, agitated, and he went into full-blown cardiac arrest. After an intense cardiopulmonary resuscitation and early defibrillation, luckily ROSC was achieved, and he was transferred to the cardiac center for primary PCI. There, he suffered 100%. It was found 100% occlusion in the left anterior descending artery, for which thrombus was aspirated and stent was placed. Despite the initial procedure, he persistently had ST segment elevation on the cardiac monitor, and he was taken again to the cath lab for relook, considering stent thrombosis, but there was no stent thrombosis. With the consideration of myocardial staining, medical management was continued for 3 days. Luckily, he was discharged with full neurologic recovery after 3 days. These are the investigation summary. This is the EKG shows anterior and anteroseptal and lateral lead segment elevation with lactate of 4 millimole per liter. Subsequently, he had cardiogenic shock. The cardiac troponin is elevated to 29,823 picogram per ml. Otherwise, the renal function is okay. The liver function is slightly elevated. Coagulation profile and electrolytes are in the normal range. The post PCI echo had anterior, anteroseptal, and apical hypokinase with LV ejection fraction of 45 to 50. Otherwise, no pericardial effusion. This is the procedure done. As a discussion, widowmaker heart attack describes a stress condition with LAD complete occlusion. The management should be started right away in order to salvage the patient. If cardiac arrest occur, SLS must be followed, and PCI and CABG option has to be a consideration. As a take-off message, this case highlights the importance of early detection and management.
All right, welcome back, everyone. Thank you so very much for your patience. As you can tell, it was a very, very tough decision. All of the cases were absolutely fantastic. Like I said, we spanned quite a bit of topics, learned quite a bit from all of you, again, across 4 continents and 9 different countries. Wonderful examples of emergency medicine throughout the world. So thank you all so very much for tuning in today. Again, to all of those who presented and their mentors, congratulations. This was a wonderful, wonderful case competition. So without further ado, we will announce the results. Just as a reminder, the top prize is $1,000 US. Second place is $500 US. Third place is $250 US, and People's Choice is also $250 US. So here are the winners of the competition. So in first place, Dr. Baptiste from South Africa, talking about tension pneumomediastinum. In second place, we have Dr. Fogel, also from South Africa, looking at organophosphate poisoning. In third place, we have Dr. Tu Thang from Vietnam, talking about PE. And then our People's Choice winner for the day was our first presenter of the day, Dr. Adamako, with spontaneous hemoperitoneum. So congratulations again to everyone who presented, but a sincere congratulations as well to all of our winners for the day.
And thank you. So thank you all again for everyone joining us today. I will be in touch with our selected top finalists in communicating to you how you'll be able to get your cash prize. You all should be receiving an email in about 2 days or so with a link to this recording if you'd like to share it, and then also tomorrow a link that an email that includes a feedback survey. So if you haven't completed that, please do so. As this is our first case competition, we really value your thoughts and opinions about how we could improve this the next time. So once again, thank you all very much. And please have a great rest of your day or evening. Thank you.
Just another huge thank you to all of you. I want to say thank you to Alejo here, who you were just hearing from, who helped coordinate this entire case competition. He did all of the hard work behind the scenes, getting everything organized and put together. So thank you so much to Alejo, to the University of Pennsylvania Perelman School of Medicine Center for Global Health, to the University of Pennsylvania Department of Emergency Medicine for co-sponsoring this event. Again, to all of our judges, our fantastic keynote speaker, Dr. Ghazanfar Salim from the Indus Hospital and Health Network in Pakistan. And to everyone who presented today, thank you so very much. Congratulations to the winners. Please, please, please give us your feedback and look forward to the next case competition. We're hopefully going to have another one at the end of the calendar year, probably sometime in November, December. So stay tuned. Thank you all so very much. I hope you have a wonderful rest of your day.